Good afternoon, everybody. I think we're going to start the session to stay on time. We have an interesting program this afternoon. My name is Osman Ratib. I'm from the University of Geneva, and I'll be chairing this interesting session about nuclear medicine innovation on a topic that is probably the next biggest thing in nuclear medicine, which is theranostics. Without further ado, I will open this session, and it's my pleasure to introduce Professor Rodney Hicks, who you probably all know. He's the director of the Center of Cancer Imaging at Peter MacCallum Cancer Center in Melbourne, and has a very large experience in clinical and preclinical research. And now he's going to introduce this topic, telling us more about theranostics.
So I figure most of you know what theranostics is, but I thought I'd go into a little bit of history. I'm entering my anecdotage now, so I'm going to tell you some stories. Of course, therapeutic nuclear medicine began well before we had imaging. In fact, Marie Curie, when she separated radium, she gave a sample to her husband, Pierre, and he took it in his fob pocket to a lecture and got a burn that he noticed took a very long time to heal, and he consulted a friend of his, a physician by the name of Henri Alexandre Danlo, of Ehlers-Danlos fame, who thought, well, maybe this would be a good treatment for skin cancers or for skin conditions. And that started the therapeutic use of radium-226 in treating skin cancers. And we're very early adopters, as Eric Krenning will know, of new technology. Within a few years of the publication or the use of this in France, the St Vincent's Hospital just down the road was applying it in their outpatients. Some people who've been to the outpatients of St Vincent's Hospital will know it's not much different these days. People are treating themselves there with various medications, some of which are licensed, most of which are not. But it's an interesting place. Radium was then used topically for a wide range of malignancies, basal cell carcinomas. You can see the before and after results, applying pellets to salves to the soft pellet, got rid of squamous cell carcinomas, at least for a period of time. And so this was a very popular treatment in the early 1900s. When Ernest Lawrence first made a cyclotron, he could make a whole range of new radiopharmaceuticals, and just happened to have a brother by the name of John Hundale Lawrence, who was a hematologist. And some researchers, Blumgart in particular, had been giving P32 to do circulation studies in the heart, where they used a Geiger-Müller counter on the vein to look at the circulation through the heart. And they noticed that some of these patients were becoming a bit anemic. He asked his brother, he said, well, maybe this would be a good treatment for leukemia. And he took a patient, in fact, a medical student who had chronic myeloid leukemia, for which there was no effective treatment, and gave P32 and got quite a good remission. The white cell count went down, and he thought this was a pretty interesting therapy. And also working at Berkeley, where Lawrence made the first cyclotron, was this physician by the name of Charles Pescher, who was interested in calcium metabolism and looked on the periodic table and saw that strontium was in the same class as calcium. And maybe that would be a good way to study bone metabolism, and knew that sclerotic metastases were very common in prostate cancer, so he gave strontium-89 to a patient who miraculously had their pain go away, and he thought he'd found a cure for prostate cancer. In fact, he was very excited about this, but this was all subsumed because it was in the early 1940s in the Manhattan Project, and it was a trade secret, and he was ordered back to Europe in World War II, and he was so depressed about that he jumped off the side of the ship. And so he never got to investigate and know that the agent that he really discovered was going to be used therapeutically. Glenn Seaborg, also involved in the Manhattan Project, but one of the first things that he made was various isotopes of of iodine, and various clinicians got access to that, one of whom was Sol Hertz, and Barbara Hertz is in the audience, recognising the history of her father in treating for the first time patients with thyrotoxicosis with radioactive iodine 77 years ago last month. We've really long history, and nearby Sam Seedlin used this to treat patients with metastatic thyroid cancer. And in those days, he went round with a Geiger-Müller counter and measured the bone lesions using a counter. There was no imaging. And so the real revolution in these was the recognition of the therapeutic effect of internal radiations. And the unifying thing of all these examples, you started with a scientist who had a new technology or an idea. And that was mixed with a physician with an open mind who was thinking physiologically, if you like, about pathological processes. And the most important one, probably, and still for many of our theranostic applications, is the idea that you have patients who lack therapeutic options. So therapeutic nuclear medicine really grew out of the interaction between scientists and clinicians focused on patient care without access to imaging. That all changed with the development of the rectilinear scanner and Benedict Cassin's original rectilinear scanner, photo printing of organs like the thyroid gland, so we could see what was being treated. And that's become really the ultimate paradigm for theranostics. It's one of my patients from the early mid-90s who we were ablating for thyroid cancer, and to our surprise, despite a normal CT, lots of sites of disease in the lung, the sensitivity of the imaging paradigm. A single cycle of that treatment led to complete clearance, not only of his normal tissue, but of his metastases in the lungs. But he developed brain metastases, confirmed on MRI. Another single dose of a single agent to metastatic disease in the brain cured him of brain metastases. And so an incredible story of efficacy and safety in this man. In fact, he went on to die of prostate cancer. Unfortunately, we didn't have lutetium PSMA to treat him at this stage, and he died of that disease. So here's the venerable temple of oncology, and radionuclide therapy is one of the earliest pillars that we've had. And the pediment on which our choices stand are disease localisation and characterisation. That's something that we can do in molecular imaging uniquely, the ability to localise and to characterise disease. And so theranostics is a targeted therapeutic with a diagnostic companion, with the idea of giving the right therapy to the right patient at the right time, and also iteratively using the same target to monitor the therapy that we deliver. My first experience of theranostics above and beyond thyroid cancer was at the University of Michigan, where Bill Bywarders had the idea, well, if iodine worked in thyroid cancer, maybe if you use a different targeting moiety, in this case a precursor for catecholamines, maybe you could treat other endocrine diseases, because there were no effective treatments for diseases like metastatic pheochromocytoma. And he went and spoke to his chemist, and Mike Kilburn and his colleagues made iodine-131 MIBG, which is still both a diagnostic with iodine-123 or iodine-124 and a therapeutic with iodine-131. So that theranostic paradigm extended beyond thyroid cancer. This was the very first patient that I saw in the clinic treated with radioactive iodine. Barry Shulkin, I think, is certainly at the meeting, I don't know if he's in the audience, with Bram Shapiro and Jim Sisson, treated this guy. He was a short order chef, and interestingly, I saw him after this treatment, and he lost all the hair over this lesion. He had very frizzy hair, and it all fell out in a circle around this lesion, suggesting that he got at least 60 grey to the roots of his hair. He also was quite famous because he had polycythemia, which we now know is associated with the HIF2 alpha. And so even before we knew the genetic basis of many of these diseases, we had therapies that could image them and treat them. And treat them we do, and we get, again, fantastic resolution of both symptoms and the imaging target disappearing. This is a patient we treated over a number of years with iodine-131 MIBG for metastatic pheochromocytoma. The story that I guess many of you know about and now become a very celebrated part of the history of theranostics is the treatment of NET, neuroendocrine tumours. Started with a scientist, Jean-Claude Roiby, with a chemist, Steve Lambert, who put them, this was the target, this is the targeting agent, and clinicians with open minds who were thinking, here's a group of patients that have effectively no treatments. And Dick and Eric really did a fantastic job in developing this paradigm, which is now a commercial product in both the diagnostic and therapeutic sense for us to use. And the real beauty of this is the disease has a very high expression. The vast majority of tumours of the neuroendocrine system express this target, and it has a biological effect on the growth of these tumours. So this paradigm of having a targeting agent linked to a radionuclide, to me, is a bit like a revolving door that you need a key for, and the key in many of these diseases is a peptide, but sometimes an antibody. You need key rings, which are chelating agents, and you need dangly bits, and they're the radionuclides. They're the things that give beauty, if you like, to your theranostic agent. And the good thing is we've got a whole lot of really cool key rings that hang there. We've got ones that are pretty safe and friendly to us, like gallium-68. We've got some that are act by a bit of stealth, like Spider-Man here. We've got Superman, which is lutetium, and maybe the Incredible Hulk, which is yttrium-90, in terms of the different physical characteristics, the path lengths of the particles that they emit, and the kind of radiation affects how they interact with tissues. As well as that, we have an incredible array of therapeutic agents that have different half-lives, different energies, different kinds of emissions, from beta to alpha to a combination of beta and Auger electrons, all of which are going to have different biological effects, and many of them have therapeutic pairs, again, with a range of half-lives that can be matched to the biokinetics of the process that we're interested in imaging. So we're really spoiled for choice in theranostics. And I think that the field is going to open up as people start to combine different radionuclides for diagnosis and therapy, depending on the targeting moiety that we have. And so the prototype in neuroendocrine tumour, the target is somatostatin receptor, the peptide is octreotate, the key ring, if you like, is DOTA, and the radionuclide, the dangly bit, is lutetium. We call it lutate because we think the important thing is the dangly bit and the key, not the key ring. People who call it dotatate, I think, sort of ignore the most important bits of the molecule. Commercially, that's obviously known as Lutathera. The approach is a very simple one. It gets into the cell, gives off a radiation that damages DNA, and that hopefully kills the cell. And the real advantage we have is the crossfire effect that you get from particles that go a distance in tissue. And the further they go, the greater the crossfire effect, but also the greater the collateral damage to cells that are outside the tumour deposit. And so again, marrying the size of a lesion, optimising that, and the heterogeneity at a microscopic level. Yttrium might be good in big lesions or heterogeneous lesions where you need a longer range of your beta particles, or lutetium where you want a denser radiation cloud in a smaller deposit. The effects, again, we have the advantage that we can see the people who are going to benefit, and we can see them benefiting real time. And this is fantastically powerful information to share with patients, to show them their scans, that they will likely respond or have got at least a chance of responding, and that they have responded. That does translate. Now, this is the famous NETA-1 trial, but that really just recapitulated work that Dick and Eric and other groups had done, showing this is a highly effective therapy. It does delay the progression of disease and also probably improves overall survival. Not only does it treat the oncological manifestations of disease, it also treats the hormone secretion, which is, in many of these patients with very slowly progressive tumours, a bigger problem than oncologic progression. This is a patient, for example, with insulinoma, intractable hypoglycemia, was on dextrose infusion, steroids, diazoxide, nocturnal feeds. He was in hospital. You can see 3 months after 4 cycles of lutate, there has been a response on the scan, reduction in the amount of tumour, but more importantly, the patient was now normoglycemic, was off nocturnal feeds and only on very low dose steroids. And out to 2 years, the patient came off all medications, no longer Cushingoid, had a completely normal performance status. And that's despite the ongoing presence of disease. This patient hasn't been cured of their cancer, but has been cured of their endocrine symptoms. Of course, we now recognise increasingly that tumours are heterogeneous. Pathologists have been seeing that for some time. If you look down the microscope of a neuroendocrine tumour and you just measure the proliferation rate, you'll see that there are little islands of proliferating cells and non-proliferating cells. There are cells that have somatostatin receptors and those that don't. These are 2 extreme examples of a low-grade neuroendocrine tumour on the left and a high-grade neuroendocrine tumour on the right, and 2 scans in the same patient. So if we look at the somatostatin receptor imaging, fundamentally different responses. The patient on the left has lots of lumps, if you like, in their liver. The one on the right has none. So if we're counting lumps, the sensitivity across those 2 patients of the total number of lumps is 50%. 0 in this patient, 100% in this one, whereas vice versa, the sensitivity of FDG is 50% as well, 100% in this patient, 0 in that patient. What we're looking at here are different subpopulations in a tumour spectrum, that as the tumours dedifferentiate, they tend to lose the differentiation marker of somatostatin receptor, and they start to become card-carrying cancers using more glucose. This is important because it tells us about the prognosis of the patient, but also what's a therapeutic target. In one patient, we can use somatostatin analogues, in the other one, we can't. Now, it's very rare that we see so exclusively all or none. In fact, it's been looked at by a number of groups, but you can see that as tumour grade goes up, so somatostatin receptor positivity goes down. But when they are positive, they tend to have a better prognosis than those that lack it, which is probably because this is a surrogate for tumour grade to some extent and differentiation. But conversely, even some of the low-grade neuroendocrine tumours still have FDG avidity, but it goes up with increasing tumour grade. But the prognostic significance of that is completely opposite. They have a terrible prognosis relatively to those who are PET negative. And so we've started to conceptualise this that in conceptual terms, the a priori likelihood of somatostatin receptor expression, the green line here, tends to decrease, particularly at very high-grade tumours. But not all high-grade tumours lack receptors. And similarly, not all low-grade tumours lack FDG avidity. Some of them have it, but as your grade goes up, they tend to become more FDG avid. And so we have really three zones here. The zones that have somatostatin receptor expression, no FDG, which most people think are the group that need peptide receptor radionuclide therapy. These who are clearly unsuitable because they lack the target. And a group here that have a poor prognosis but still have the target. And they're probably the people that oncologically need the treatment most because they're going to do the worst. And so we deliberately chose these colours. Stop, don't think of using PRRT, go, just don't even think about not using it maybe. And these are the ones you have to proceed with caution, worry about, but it's good fun going through amber lights because the red light camera doesn't flash and you don't get a ticket for doing that. So in this paradigm, we can start to then identify subgroups of cells which are suitable and unsuitable for our therapies. If you look at these, ostensibly they look like the distribution is similar. There's a big lump there, there's a big lump there, there's a couple of big lumps there. You can see that perhaps you'd go ahead, and if you only had this scan, you'd say this patient's perfectly suitable for PRRT. But in fact, if we go through and we look at them and we do subtraction, you'll see that there are areas which are spatially concordant where both targets are expressed, and there's other areas which are spatially discordant where only FDG is expressed. And obviously we can't target that component of the disease, and unless we control that with another means by chemotherapy or embolization or resection, we're not going to cure this patient with PRRT because we simply can't target what is almost certainly the most aggressive and poorest prognosis part of their disease. And so this concept of spatially concordant and discordant disease is a very important one. This happens not only in neuroendocrine tumours, but in other, or within the spectrum of neuroendocrine tumours. This is pheochromocytoma with MIBG and indium octreotide scans, and you see that there are some lesions which are expressed in one but not the other, and vice versa. So potentially we can combine these therapeutic targeted agents to hit all the subpopulations of cells with different off-target toxicity. Obviously, the indium octreotide goes mainly to the kidneys, whereas the MIBG goes mainly to the bowel. So we've got non-overlapping toxicity, we've got complementary treatment of different subpopulations of cells, and some tumours will get more radiation because both targets are simultaneously expressed. And if we can target it, we're likely to get good response. This is a patient with widespread metastatic paraganglioma, very high somatostatin receptor expression, very little MIBG uptake, but you can see over a period of time this marked regression of disease. But more importantly, the catecholamine levels in this patient also went down. And so there's the 21 months after PRRT, an excellent response in the patient. So how do we get to choosing the right treatment in patients? There's heterogeneity, even with a disease as rare as pheochromocytoma. We currently know that there's at least 5, maybe 6 different subgroups. And if we look at the cosmic database for gene expression, you can see that certain tumours, for example, have much lower expression of the norepinephrine transporter. That's what that's the target for MIBG. But they also, within that pseudohypoxia group, they have high GLUT1, so they're well imaged with MIBG. But within that group of succinate dehydrogenase B and VHL, which are the same in terms of their expression of the norepinephrine transporter and largely similar in terms of their glucose use, you can see that VHL has very low somatostatin subclass 2 receptor expression. And when we looked at in a tissue microarray, exactly what we've found also in imaging, that the VHL subgroup lacks somatostatin receptors, so it's not worthwhile doing that. So maybe in the future we're going to be able to do a restricted gene set of our tumours to look for imageable targets and therapeutic targets in the theranostic area. This is another exciting area of development in the prostate cancer, the PSMA expression that goes up as tumours become more aggressive. It's exactly what you want. It goes up in metastatic disease, exactly what you want. And it's also involved in neovasculature, which is also a feature of metastatic disease. And again, pioneers of this area, people like John Babbage and Michael Eisenhut at the German Cancer Centre followed on with work that Klaus Kopke and his group have done, and many other clinicians and chemists working in this area to reproduce really what's been done in other endocrine-related tumours. And this has really been a game changer. This was, I think, the very first or second patient we did with PSMA. There's co-registration with MRI. You can see the primary. You can see a 3 or 4 millimetre lymph node here with sort of really quite remarkable sensitivity. And we saw a 4 millimetre additional deposit in the prostate, which had been overlooked, but there on the MRI. So incredible sensitivity. And because we can see it, we can treat it, the theranostic paradigm, and I'm sure Michael Hoffman, who's talking next, will talk more about this dosimetric evaluation, but there we have the pre-therapy target and the post-treatment ability to treat these patients. And here's the before and after pictures. Dramatic response paralleled by improvement in symptoms, reduction in PSA, but unfortunately not necessarily curing the patient, certainly not in this case with small volume disease coming back. But what we've brought here is significant quality of life and durability of life for a patient who lacked other therapeutic options. We're now increasingly recognising the same thing that happened in neuroendocrine tumours, that there are subpopulations of cells that lack the target. They can have low target expression, or they can have discordant disease. So here's a patient with an FDG-avid mediastinal mass that lacks PSMA, and clearly we can't target that. So we have to think of either combining our therapies with other agents or excluding these patients from active therapy. And so we're getting to a point of not only choosing patients better and delivering the radiation better, but also selecting how we might combine our therapies with other therapies. This sort of fits into, I guess, the paradigm that people have called convergence medicine, where you're looking at biomedical research, clinical medicine, omics, matrix. And people put this out as a new idea, but in fact, we are and have always been the prototype of convergence medicine. We've had patients lacking therapeutic options who are really powerful motivator to do new things. We've had, and we need, oncologists with open minds to look for new therapies, and the nuclear medicine physician can bring those together by identifying therapeutic targets. We work with the pathologist to identify molecular targets, particularly with new immunohistochemistry tests. We can test for our various targets. We have always been highly reliant on the expertise of radiochemists, who are supported by all sorts of new innovations in the laboratory sciences, particularly genomics, proteomics, and so forth. We have a big imaging team behind us, which allows us to do our theranostic selection, and they're supported by a whole lot of technologies in the physical sciences, and that gives us new therapeutic options. So we're bringing together all these different groups, and superimposed on that, we have the huge advances in molecular biology and genomics, which are telling us about targets. We have a whole lot of new artificial intelligence that can start to segment the images in a way that it's very difficult for us to do conceptually. We can see the big differences. We can't necessarily always pick the small ones. And we have an industry that's suddenly become interested in theranostics, and that's really a great opportunity for us. But we need to learn the lexicon of our partners. All of these people we need to interact with, we need to learn their language, and we need to work out what motivates them. But the central thing here is the patient that we started with who lacks therapeutic options, and that's a great opportunity for us. We also need to learn to deal with politicians who lack vision. As you can see here, I don't know what he's looking at, but he's not seeing much. And unfortunately, they're always ready for war. And so I've spent the last 20 years of my life fighting politicians. I hope you'll all join me in that fight, and thank you very much for your attention. I have one more advertisement. We have the Asia Pacific Neuroendocrine Tumour Society here in this very convention centre from the 9th to 11th of November, which coincides, the 10th of November is World Net Day and also my 60th birthday, so you're all invited.
Thank you very much for this very exciting and enthusiastic introduction to the topic. And I think we do see all the different potential of groups colliding or collaborating for making this happen. We're going to move on. We decided not to have questions for this introduction, so we're going to move on now to the hot topic of today. Since we're introducing personalized medicine with theranostic and treatment with radioisotopes, there's a big question that still has not been answered, and it's very controversial about dosimetry to the patient. It's not like chemistry or traditional drugs. We need to develop our own way of adapting or not the dose to the patient. What is the advantage and disadvantage of doing so? So we have two speakers today that accepted to take one side and another, and they will give us their one opinion and the other opinion, and we will have those two presentations back to back, and we'll open for discussion right after that. So the first speaker is Michael Hoffman from the same group, and he's going to take the pros side of new challenges in patient-specific dosimetry in therapy radiopharmaceutical.
Thank you. I wasn't asked whether I wanted to speak for the pros or the cons. I think it was Dale Bailey that asked me to do this talk. So I was lucky to get the pros. It's definitely the side I would have wanted to talk about. So this is how dosimetry is done. This is a patient who's received lutetium PSMA therapy. And most of the talk, the images will be PSMA based, but they could be lutetium dotatate, or they could really be any other therapeutic that we can image. And you'll see this patient's had a series of scans, I think 5 scans over a multi-day period, and a physicist has spent an enormous amount of time drawing regions of interest on each scan. And there's a lot of overlapping features. The kidneys are overlapping the bowel, and these images are not particularly compelling. They don't sell a particular story for our referring base. They look at these and they don't know what it means. So this is our conventional planar MERD dosimetry, and if we're going to do dosimetry this way, I would say I should have been speaking for the cons. But this is the way we do dosimetry, which is voxel-based dosimetry. So we can now produce a single image. This is a patient treated with metastatic prostate cancer. You can see the scale. Anything in red received 50 grey or higher, anything in the grey scale, 0 to 15 grey. And we get this nice whole body overview image, which is kind of self-explanatory. The referrer can look at this image and see exactly what's happening. We can just, this is actually in DICOM format, and every voxel is in grey. So you can load it up on your PACS workstation and just put a region of interest around the adrenal gland. And instead of reading the SUV mean, that number will come out 68 grey, which is the mean dose to that kidney. Or you can put your region of interest over the parotid gland and get 4 grey. Very compelling images. So I think if we do dosimetry this way, it's one, very cool, but also helps us and our referrers. So how do we do it? How do we get an image like that? It's much easier than it used to be. The first step is we need to obtain a post-therapy image where every voxel is in megabecquerels per mil, like what you get off a PET CT scanner. In the past, SPECT CT has been non-quantitative, but this has really changed. We've developed our own in-house method, which we published back in 2011. Back then, we did a standard SPECT CT acquisition, but then in order to convert from your counts per second, which is what a gamma camera gives you at the time, to megabecquerels per mil, we had to do a fairly laborious exercise of filling this phantom with 0.5 gigabecquerels all the way up to 16.5 gigabecquerels and doing a map so that we could convert the known activity to the counts per second and account for this dead time correction. As you get higher doses, your crystals get saturated. And this took many, many hours to do. but it's very accurate. And we would then run a batch file, and it would convert the SPECT file to a PET-like file where every voxel was in megabecquerels per mil. And how accurate is this? Well, the way we validated it was in our neuroendocrine population. We knew we'd just given them a dose of activity, like 8.3 gigabecquerels of lutetium dotatate. We then essentially did a whole body SPECT CT and put a region of interest around everything and said if our dosimetry is accurate, we should recover 8.3 gigabecquerels. And here's the deviation from the actual reality. You can see it's very accurate. It's within 5%. So a SPECT CT camera is a very accurate dose calibrator. Now, things are much easier now because that was our in-house method. Nowadays, when you buy your SPECT CT camera, you'll get quantitative SPECT CT out of the box. And really all the manufacturers are slowly coming on board with this. This is the Siemens X-SPECT Quant, and we've got 2 Siemens cameras. So now we're switching across from our in-house method, which is a little bit clunky, to the commercial version of it. And they show accuracy within 1%, which is what you would expect. That gives you one scan with megabecquerels per mil. You then need to convert that to lesional dose. So this is step 2, and we're still using our in-house method that Price Jackson, our physicist, has put together with the rest of the team. And this is an automated voxelized dosimetry tool. So what it does is it takes 3 SPECT CT scans at 4, 24, and a late time point. It registers the CTs together, fuses all those images together, and essentially looks at the area under the curve for each voxel, applies an S factor, and then you can work out the dose in that individual pixel or voxel. So this is how it works. This is a post-PSMA SPECT CT scan. There's 3 scans, 4, 24, 96. We've done 3 bed-step SPECT CTs, so we can include a good amount of tumour, but also the salivary and renal tissues, the organs of interest. You can see that these are quantitative images. They're all scaled according to a megabecquerels per mil scale. We fuse those together, and then we can derive the dose in various tissues. And this is the image I showed earlier. This is, I think the best way to demonstrate our ability to do post-therapy dosimetry. So we put this into our viewer, and we can just trace around the kidneys. Our MIM software will do this automatically. We can just say put a region of interest around this area. It'll do that very quickly in 3 dimensions. We can do the kidneys, the parotid glands. We can put a region of interest around all the tumour, a bit like a metabolic tumour volume on your PET scan very easily. We can change the colour scale to my preferred colour scale for dosimetry and get these really neat images. We can then just look at the SUV effectively within these contours and derive a mean or maximum dose. And you can see this new metric that we're now using a little bit of whole body tumour dosimetry. So rather than picking out 1, 2 or 3 hottest lesions, which may not be representative, we're getting an idea of what is the average dose to all the tumour in this patient. And they'll be lower numbers than what you expected because they're a mean. But you can see it's still a lot higher than the parotid or the kidneys, and the maximum dose to a site of tumour of 112 gray is fairly impressive. This is from a single cycle of therapy. This is our results from the first 30 patients that we treated prospectively with lutetium PSMA. Each patient's represented by a dot. You can see the mean doses to normal tissues and the mean doses to tumour, which are more variable and very safe limits in our normal tissues. What does this mean? Can we predict from the dosimetry the response? And indeed we can. So on the right here are patients that had a PSA response over 50%, and you can see they had much higher doses on average than patients who did not achieve a 50% response. And if we look at this group here, this lower limit of dose, in fact, if you got below 10 gray to tumour, there was only 1 responder and 10 non-responders. So I look at this and I think, in the era of personalised medicine, can we actually use dosimetry to identify treatment futility? So it seems if you're getting under 10 gray after your first dose with lutetium PSMA, the chance of a response is negligible. Perhaps we should abandon therapy in this patient and say what other treatment options are available to this individual patient. We've also described a sink effect. We first did this with gallium dotatate. and we've now shown the same effect with PSMA. So this is tumour burden. As the volume of disease increases, the dose to the parotid gland decreases. And this is quite a significant inverse exponential relationship. So if we look at a patient on the left side with small tumour burden and a patient with a very large tumour burden, sort of 250 mils versus over 3 litres of disease, should these patients receive the same administered activity when we treat them? And I think the obvious answer is that that shouldn't be true. We should be giving a much bigger dose to this patient and a smaller administered activity to this patient. It gets a bit laborious to do all those regions of interest, and our physicist, who's very smart, thinks, oh, I can get a computer to do this better than I can. So he's developed an algorithm that takes the CT scan, finds the middle section that has the kidneys, and then automatically segments out the kidneys using an atlas-based sort of artificial intelligence learning method. And that way we can plug in a whole cohort of 30 patients, and the computer very rapidly just does regions of interest around the kidneys. And he's then compared the manual contour, which I've done around the kidneys, compared to the computer automated contour, and you can see they match pretty closely. So that's a very neat way to do rapid renal dosimetry on a whole cohort of patient, almost the computer doing it by itself. If you look back think back to that very first slide I showed of the MERD classical two-dimensional dosimetry, it can take a physicist 3, 4, 5 hours just to do dosimetry on a single patient. And here, the computer can do 30 patients in a very short amount of time. Now, one of the limitations is this concept of needing 3 time point images, a 4, 24, perhaps a 96-hour image. That's a lot of scanning. It's both uncomfortable for the patient to undergo that many scans. It's costly to be using up your SPECT CT scanner, scanning patients at multiple time points. So the question is, can we derive the same information from a single time point? And it seems that indeed we can. This is our own data in neuroendocrine tumours. So once we know the clearance kinetics of a particular tracer, in this case lutetium dotatate, we know its average clearance from kidneys and tumour, we can then make some assumptions from a single time point. And if we take the late time point and compare it to the accurate dosimetry, it's only 6% out for both normal organs and tumour, which is pretty good, considering that that's a lot quicker to do. If you just take the 4-hour image, the early time point, it's really very inaccurate. So if we're going to do single time point dosimetry, it's clear that we need a late time point. That's where the value is, and the accuracy is within 5 to 10%. I note a publication, I think in the current edition of the Journal of Nuclear Medicine, actually showing exactly the same thing. A very high Pearson's R value of 95.95 for a single time point 96-hour image, and they conclude that an absorbed dose to both tumour lesions and abdominal organs can be deduced with reasonable accuracy from a single time point measurement. Another good reason for doing dosimetry is that increasingly we'll be required to do it. The European Association of Nuclear Medicine has come up with some guidelines, and they're essentially making it mandatory for every patient who's having a dose of therapeutic radiation to undergo some form of dosimetry. Now, if you were going to do it MERD method with 5 whole body planar images, that's very labour intensive, but hopefully I've shown you that with a voxel-based technique, it's increasingly easy, accurate and informative. In fact, I think our voxel-based technique is actually a lot easier to perform than planar images. And we can move forward further with a single time point. This is feasible. We can produce some really cool dosimetry map images that are very compelling for both us and our referrers. And we can start also looking at tumour dosimetry rather than just normal organ dosimetry. And as you've seen, there's potential to really fully automate this so that minimal human intervention is required to do this. So thank you very much.
Thank you very much for this very convincing pro, and now the challenger, or a difficult task to take a position on the cons and maybe explain why it may or may not be relevant clinically to do the dosimetry. And that's Professor Alexander Haug from Vienna, who's going to be taking that difficult task.
Thank you. dear colleagues, when I started my scientific career, I worked on the radionuclide therapy ward, and I recognized that we treated really many patients with neuroendocrine tumors, and I recognized that we have follow-up for almost all of these patients. And then I thought myself, I had a great idea. I thought, why don't we compare dosimetry with the follow-up of the patients? And with this idea in mind, I went to my medical physicist and I told him about my idea, and he looked at me and then told me, it's not that easy, it's complicated. And believe me, I often heard this when I talked with physicists about dosimetry. And with this history in mind, I had some fruitful discussions with Thomas Bayer. Some of you might know him. He's a colleague and physicist of mine in Vienna, and as a result of these discussions, so one of the results is that I'm standing here and are playing the devil's advocate against dosimetry. So let's start. Dosimetry is time-consuming. It's labor-intensive, and it's also patient time we spend. And that makes it quite expensive. So what do we expect to justify these efforts? Of course, we want impact on clinical treatment. And how can we get this impact? We can either avoid toxicity, and therefore we need, of course, organ-specific thresholds for toxicity, or we want to improve accuracy, and therefore we need thresholds for response. Or in other words, I want what radiotherapy has already achieved years ago. I want to start with radiojodine therapy, where dosimetry is quite well established. So for ablation, we have fixed activities adapted to the stage. And for metastatic disease, I call it so-so. We know already since the time when I was in primary school that there is a correlation between dose and response. And we know also there is a certain correlation between blood dosimetry and toxicity. There are also attempts using iodine PET with mixed results, and still most use fixed doses. This is a survey with several centers in Europe where they asked the physicians, do you use dosimetry, yes or no? And if you take a look at metastatic disease, you can appreciate that almost all centers use fixed activities with some adjustments to clinical parameters, and almost nobody adjusted the dose to the target, the activity to the target dose or to organ at risks. And why is that? Because radiojodine therapy works fairly well using fixed activities. We have some drawbacks for pre-therapeutic dosimetry, and we have quite few side effects in most patients, which might prompt the need for optimization. Or in other words, it's kind of a feeling most physicians have that the benefit does not exceed the effort. Now I'm talking about PRT and neuroendocrine tumors. What's there? First of all, I want to start with some consideration. And my first consideration is that lutetium should be preferred over Y90. With lutetium, high-grade nephrotoxicity is in fact absent. It's in studies below 1%. We have a rate of 15% of hematotoxicity. So the goal of dosimetry should be to increase activity as much as possible. Again, same survey, status quo. What is the status in PRT and dosimetry? And you can appreciate that more than 50%, this green button is PRT, that more than 50% of the centers never or seldom use dosimetry in PRT. And almost nobody adjusts the activity to the organ at risk. That's below 10%. But the vast majority uses fixed activities. So there are huge efforts performed in dosimetry. These are the publications about dosimetry and PRT in the years. Publication of increasingly sophisticated studies about dosimetry, and it has no impact on treatment. There's something going wrong. And why is that? I hope all of you agree we have this useless threshold of 23 grays for the kidneys, really useless. We have no correlation between kidney dose and nephrotoxicity. And that might be in part because we hardly see nephrotoxicity in these patients. This is just one study who correlated the BED to the kidneys to the change of the GFR, and there was no difference between patients with a high dose to the kidneys and a low dose to the kidneys. So we have no threshold. And partly the same is true for hematotoxicity. This is with Y90, with which they correlated the change in blood count with the uptake with the dose to the blood. And if you just 50% decrease as a marker for toxicity, you cannot find a threshold who will tell you, will this patient develop hematotoxicity or not? And quite the same is true for lutetium dotatate, where you have a slight correlation between the dose to the blood and the decrease of the platelets and a decrease to the leukocytes, but it's not possible to draw a line for the threshold. It's a little bit different with efficacy. So dose response relation between the dose to the tumor and a decrease in size seems to be present. Has this study shown that, for example, below 200 gray, you have a partial response in the lesions, but these are only few patients, and I think it has to be confirmed in larger studies. So I'm not convinced. And I think to justify the efforts, we have to increase the impact of dosimetry on treatment. We need large studies to identify thresholds for toxicity and efficacy. Therefore, we have to harmonize how we do dosimetry, and we need a standardized follow-up to do so. Another point is, why do we stop after 4 treatments, given the absence of nephrotoxicity, and there is still some room for improvement of efficacy? Scenario B, if we won't achieve this, is do it like Big Pharma. Look at Xofigo, look at the NETA study. There is no dosimetry in these studies. They have done classical dose escalation studies, like with any other drugs. They neglect individual differences in organ doses. We agree on acceptable toxicity probabilities and use then fixed schemes, like we now do, but then with a solid scientific basis. Lutetium PSMA, short story. Same survey. You see that in majority of cases, dosimetry is used. And if you go back 15 years, I think for PRT, the numbers would be the same. Why do we use dosimetry? Because it's a new treatment. But again, dosimetry has no impact on the treatment scheme. So there are studies that report about organ and tumor dose, but there are no studies published who report about a correlation with toxicity or response so far, which we need. And you could even argue, why should we use dosimetry in lutetium PSMA? Most of our patients, prostate cancer, castration-resistant prostate cancer is a very aggressive tumor biology. You cannot compare it to neuroendocrine tumors. So the patients have a poor prognosis, at least the given patient population at the moment. These are patients without any other kind of treatments, and survival is comparable low. So I think we have a rationale for treat until you get side effects, just unlike with chemotherapy, for example, because hematotoxicity is mostly reversible. Nephrotoxicity needs a long time to develop, and carcinoma, especially at least when you use lutetium, is not hardly patients will report you about severe xerostomia. But there might be a role for dosimetry to increase efficacy, to take a look at the tumor dose, as we heard in the talk before, therefore establish a threshold for response and adjust our treatment activity according to this threshold. So to sum up, there are great efforts for dosimetry. There are many publications about dosimetry, but we have no threshold for toxicity. We have no threshold for response, and almost no impact on daily practice and on the treatment. Dosimetry, of course, must not end in itself. Therefore, we need large studies to increase the level of evidence, to establish these thresholds, or we do classical dose escalation studies, neglecting individual differences. And I personally think this is the direction we will go to. Big Pharma is doing it like that. But I still hope that medical physicists will give us the golden bullet, which helps us to hit the cancer more effectively. Thank you.
Thank you very much for this challenging observation. I will invite both speakers maybe to stay on the podium so we can open for discussion. I'm sure there's going to be questions. Or would you prefer to have a seat here? It's probably more comfortable. So is there any question in the audience to both? Please go to the microphone so we can hear the question.
Erin Mackay from Sydney. Just got a question for Dr. Hoffman. In the material you presented, you were talking about absolute accuracies of your dosimetric technique, but you were talking at the multivoxel level, from what I can tell. Have you actually looked at the absolute accuracy of dose reported for individual voxels? Because that seems to be what you're implying by the use of those diagrams.
Look, clearly the images are subject to effects of partial volume, which is significant with SPECT. So anything under 10 to 15 millimetres we'll be underestimating, and we don't do any partial volume correction. So individual voxels will be inaccurate, but if you talk about a lesion larger than 15 millimetres, which you could verify on a phantom, that's sort of what we're talking about when we talk about accuracy, which is what's relevant, because we're not interested in the dose to a 2 millimetre node. We're interested in the dose to a parotid gland or a tumour lump.
Any other questions? I have a question, maybe. Please go ahead.
Krenning. Yeah, we heard a story about Con and Pro. So is that real life? I would say no. The two of you are right. But who is more right than the other? For me, we have to make a distinction between lutetium. So if you talk about Con, and then your conclusion slide is all about lutetium and not about yttrium-90. And specifically, if we compare lutetium dosimetry or effects on the kidney versus the yttrium-90, it is a day and night difference, whereby the yttrium-90 is similar to external beam radiation and the lutetium-177 is similar to lutetium with a shorter particle range. The Krenning scale was a simple dosimetry measurement, and it is nice to predict the anti-tumor effect, but it is not predicting PFS. It is not predicting the OS of the patients. So there is a problem, and the biggest problem that has not been discussed here is the volume. What are you saying about the volume? If you see a lesion, we call that a tumor. Is that representing for 100% cancer cells, or do we specifically in NET include in the volume also the fibrosis or fibrotic cells, thereby saying that the total volume is not only cancer cells? Then you make a huge mistake in the tumor volume. And you showed one slide from Brussels about the effect on the remission versus the decline in the decrease in the tumor cancer cells or volume versus the dose. I know this figure very well because I was part of it. But if we say it is a 100 gray in the tumor, it can be 20, it can be 200. We lack really the data for the tumor volume, for the cancer cells. So I would say we need dosimetry for sure for every new compound we would like to introduce in nuclear medicine. But the lutetium is a nice one specifically for the lutate, there is no need for dosimetry. For yttrium-90, we know there is a maximum for, if it is coupled to the DOTA-TOC or the lutate, that you can only inject about a cumulative 300, 400 millicuries. So if you do that, there is no need for dosimetry. Would you like to do more? You need to do dosimetry. So I would say the answer is in between of your two nice presentations.
You addressed several problems. I have a question to you. Why should we use yttrium, given the results we have? So that's why I didn't talk about it, because personally, I think there is no need for it. Second is heterogeneity of tumors. I totally agree with you. That's a big issue. On the contrary side, radiation therapy is facing the same problem, but has established thresholds. So that cannot be a hurdle to obtain the results we need.
Yeah, I would agree that the truth lies somewhere in between. If I had given the cons talk, we probably would have raised many of the same points. I think the therapeutic window of the compounds we're using now is unbelievably good. So we don't need dosimetry because we don't see renal toxicity. There's no dose-limiting organ. We could do a dose escalation study with lutetium PSMA. We might get to 20, 25 gigabecquerels and not find a dose-limiting toxicity, so we would stop at a higher dose. I think this is essentially what happened with radium in their dose escalation study. The highest dose reached was not a rate-limiting dose. So if you've got such safe compounds, there's less of a need for it. And indeed, we did this 3-time-point voxel-based dosimetry for our phase 2 study, which was a 30 to 50 patient study, and now we run a 200-patient multi-centre randomised trial in Australia, and we don't incorporate dosimetry into it because it's not feasible for all 10 sites to adopt this, and it's not going to change the approach. Once you're doing a large trial and you want everyone doing the same, it's very difficult to integrate dosimetry. I think there is a role for yttrium-90 because we still do both yttrium-90 and lutetium dotatate therapy, and certainly we see patients with larger tumour and the tumour heterogeneity that I think you were describing, where we do have inaccurate dosimetry because of fibrosis, because of necrosis, hypoxia. There may be a lot of value from using yttrium rather than lutetium in those patients, and we certainly see some patients who progress on lutetium and then we treat them with yttrium and we see responses. So I think there probably is a role for yttrium.
Okay, thank you. One more question. Rich?
Rich Wall from the U.S. To me, it seems like there's a need for data. So we can make pronouncements, and they're very interesting. But at some point, comparison with and without dosimetry would really be important, I think, to determine if the toxicity profile can be made better through the use of dosimetry. The possibility, I know, perfect's the enemy of the good and all that, but at some point, this dosimetry is not that complicated. I mean, it should be possible to do in a relatively automated way. And I don't know, if you could drop the prevalence of salivary gland toxicity from 30% to 15%, if you're one of the 15% of the patients who have severe dry mouth, you might want to have that. So I guess the question would be, quick and dirty, probably not, but if you want to look across a large population, you may actually want to do that study to see how things can be modified, because we are so much in the infancy of radiopharmaceutical therapy that I think we are not fully informed. I mean, we're delighted things are working, but I mean, for instance, in the dosimetry-based therapies of lymphoma, the toxicity profiles are more consistently favorable with similar outcomes to those that are not driven by dosimetry. While they're not overwhelming differences, there are differences that emerge in larger populations. So I do think we should, before we make everything routine and it's got to be a protocol that's identical across the world, we really probably should be careful to try to determine through systematic studies, what are the incremental benefits of incorporating quantitation. So I would just caution that it's probably reasonable to do that. And to do that, I think we really as a field have to say, well, yes, it is possible to standardize dosimetry. I mean, we can do quantitative spec better than ever before. And for certain larger structures, I think we can get pretty good estimates of radiation absorbed dose. And I do think to inform our field moving forward for the next decades, we would be better informed by having strong data from databases on what dose-response relationships are in normal tissues, so that we don't have to say, well, what's internal administered is not the same as external. We know that. But to really inform this field, we need to gather those data and collect those data. And I don't think we can do it unless we probably acquire, where possible, quantitative data dosimetrically in a homogenized, in a systematic fashion. So I think there are great opportunities that we, in the infancy of the field, probably should take advantage of, or else we won't know where we are. We won't be that much farther along in 10 years. So just an opportunity.
Yeah, I would agree with those comments. I think in your opening slide, you made the point that you don't see relationship between clinical responses and the dosimetry. So why bother doing that? I think part of that is because we've treated heterogeneous groups of populations, often retrospectively. But when we look at our prospective lutetium PSMA data with a kind of very specific cohort of patients that meet particular criteria, so that they're a more homogeneous group, we do start to see some strong associations between dose and response, since the tumour biology, at least in that group, is probably more similar. And I think we see some interesting phenomenon where if you don't achieve a certain dose, the therapy does appear to be futile. So that concept of using dosimetry to decide who not to treat, I think, is an interesting one that hasn't really been explored, but we use it now really clinically. Sometimes we'll give a first cycle of PRRT, and we do this quantitative single time point SPECT CT as a routine now, and we'll put a region of interest around the tumour, and if we see something like 6 grey, we'll scratch our heads and go, this is not going to be a useful therapy for this patient, and really think about stopping and using something that's more likely to be beneficial.
Thank you. I have a quick question on that. I think we all agree that we need more quantitative data, and as we heard, the difficulty is to have the right tool. And you showed now that we're going to more automated and more standardized ways of getting dosimetry, and that the time that is needed and the effort that's needed to get it are probably going to be easier, making it easier to do either studies or just follow up on large retrospective studies. What's the plan for getting those tools available? Now that you are involved in developing that, any thought about that? Is the industry going to follow you, or are you going to provide it for open source? As an open source promoter,
I think industry has already come on board, because the quantitative spec, so that you get your image in megabecquerel per mil, is already there.
In some
it's already
machines, yeah.
done in some machines. So certainly the Siemens Intevo we have does it out of the box, and it will do any isotope. It'll do iodine, or we did a samarium treatment the other day, so we used it. So it's already there. But the second step, that is an in-house technique. I think it is actually open source. So Price Jackson has put it online. You need a little bit of physics help to set it up, but it's fully open source, and it's really quite automated. You feed in 3 SPECT CT scans with the CT. You tell it what isotope, what the time points are, which I think it gets off the DICOM header, and you let the batch file run.
I like that. Last question.
Many of us provide treatments to patients who live hundreds of kilometres away from treatment centres, even in Europe. So what's your approach in Melbourne to patients who live a long way away from the treatment centre? Do you make them stay around for several days in Melbourne in a hotel, or how do you handle that?
So for our lutetium PSMA study, I mean, that was a prospective study. They just had to comply with the protocol. And if they were from far away, we wanted a 96-hour image, and we thought we needed that for a sort of early phase study. For our standard of care lutetium dotatate, we do a 24-hour quantitative SPECT CT single time point image, and we acknowledge that that's not as good as a 96-hour or even later time point. So the error margin's greater. Instead of plus or minus 5%, it might be plus or minus 10 to 15%, but that's that's within what we're happy with. You know, if you're getting a dose to kidneys of 4 gray, 20% different will be, you know, 4.8 gray. It's not, there's not a huge difference. So 24 hours is a reasonable time period to expect someone to come back for a scan, and it's also important just for a safety check after a therapy to check that the patient was okay.
Thank you very much. For the sake of time, I would like to thank the speakers for the interesting presentation and challenging discussion. We have another topic which is also very important that we need to cover today, and we'll invite the next speaker, Dr. Richard Zimmerman. Actually, the problem is that we saw that all these pioneers that have developed those techniques have never thought about what's the economics. We all lived through an era where we were developing our own tracers and our own compound in our labs and our universities. But of course now times have changed, and there is other challenges, how to make that sustainable, how to make that commercially viable, and what's the economics behind it. So, Dr. Zimmerman.
Asked by the organizer to look in my crystal ball and to predict the future of radiotheranostics. So economics is just a word that appears in my title because I'm coming from the industry, but my whole presentation will be based on, industry, the industry position. So the most important sentence I put in my first slide is really the first one that is in bold here. It's not science that will decide what will be the future of nuclear medicine, but actually it's economics. If there is no money, there is no product on the market. And so I have just to look at the past and the past 2 or 3 years, and we have evolved a lot. There were plenty of changes in the past 3 years, and the consequence of these changes will also impact greatly what we will see in the next years. I'm covering just the period until 2025, because that corresponds to the period during which we can expect the molecules that are right now under development, so have started clinical development, to come on the market. After that, after 2025, it's more for research people. They will have to invent new things, and that I cannot predict what will happen from that point. So the first point is that nuclear medicine is now, or the industry, completely mature, so we have nothing to reinvent in terms of transport, in terms of production, so we know how to do that. There was a kind of natural selection, and I will use several times in terms of natural selection. We're in a Darwin world, and there are things that will not survive. We are in a new generation of new products, and the old products will not come back. The conventional pharmaceutical industries, that's really important. They have stepped in. That is really the really big change. And they became interested in radiopharmaceuticals quite recently. And of course, this gives a new value to the nuclear medicine segment, and that will also impact greatly the way we are working. There is much more money that will become available from now, because the way of developing drugs will be also driven by the industry. If we look just at the evolution of the market, like we see that, you see that before 2014, it was almost flat. And we started really increasing with Xofigo, and now we will have a second jump with Lutathera. But there are so many molecules that are under development that, in fact, we will see an exponential increase. And this exponential increase is only due to therapeutics and not to diagnostics. If we translate that in figures, we see that from a market that is around 4 or 5 billion today in radiopharmaceuticals, we expect to reach around 26 billion by 2013, but that is only 7% increase per year for diagnostic, while it is more than 25% for therapeutics. So the major industry trends is first that the industry has been split. The radiopharmaceutical, the diagnostic is an industry that is different from the therapeutic. We have also, we will see that all the diagnostic market will remain with the so-called older radiopharmaceutical company, while the therapeutic will be of interest for the new pharma, for the big pharmas. They come here with big money and they have interest. They have discovered that. The former radiopharmaceutical companies have almost all transformed in CMOs, companies doing marketing, doing manufacturing only. The drivers, the first point is that investors in pharma start to be disappointed by chemotherapeutics. Chemotherapy, sorry. Radiotherapeutics seems to be more efficient, less expensive than chemotherapeutics. This radio-theranostic approach is really interesting for everyone. And as I said, because the industry is mature, also the full supply chain, which was something that was did affray the industry, is now under control. If we speak about opportunities, of course, generators, for example, gallium is something, cyclotron production of generators, cold kit approach, development of centralized radiopharmacies, and the alpha therapy. There are plenty of new opportunities, so I will not develop that. We will see also new business models, like the conventional pharmaceutical industry. They can afford to put more money in the R&D. When in the early 2000s we expected to put a drug on the market for 10 or 15 million, today it's easy to think that 100 or 200 million will be put in a new drug development, but it will even become something mandatory. But that means there is a lot of money that will be available for clinical trials. We will not be limited to 50, 60 patients, but 300 to 500 patients. So there will be a need of physicians. There will be a big need of centers doing clinical trials. Also, the other point is that the industry doesn't want to sell to nuclear physicians. They want to sell to oncologists because they know only the oncologists. So that's also a new market that they are opening. Among the new organization model, we will have on one side the new structure of PET manufacturing distribution with high capacity production, but on the other side, as I said already, we have this split between radiopharmaceutical industry and conventional pharmaceutical industry. And the regulation, that is something that will actually not change. We will not have a better regulation. It will be as complicated. And constraining, there may be some uniformization, but we will still have regulation differentiate from one country to another. We will probably find ways to reduce doses, and we will find way. The reimbursement is actually directing what will come on the market. So that are the trends. If I go more in details with figures, here is a table that will give you another trend. In the year 2000, some people predicted that PET would replace SPECT. And then if we look at the number of cameras that we have in the world, you will see that the ratio of SPECT versus PET is reducing. So the number of PET cameras is increasing, but not as much as was expected. And SPECT continues to be alive. So SPECT is not dying. On the contrary, SPECT is continuing to evolving. The number of cyclotrons is quite high. We have identified more than 1,250 cyclotrons so far, almost to 1,300, but about 800 are used for FDG production, which is still enough. We should not forget that there are plenty of new fluorinated compounds that will come on the market in the next years, and this will need these underused cyclotrons, so the cyclotron is not dead either. The evolution of SPECT is mainly due to the increase of capacity or needs in Asia. PET has the fastest growth, and what we should not forget either for therapy is that we will need, in some countries at least, more shielded rooms if we want to handle more patients. So for imaging, just the trend is that PET will not replace SPECT. Technetium, the problem of supply was solved, so technetium will not disappear. MRI cannot replace nuclear medicine, and whenever possible, cold kits are much better than long preparation. Cyclotrons will continue to be needed, but there will be a shift in the use. The number of new fluorinated labeled tracer will become too large to be handled at single sites, so we will have specialized sites. All new fluorinated compounds that will come on the market will be proprietary. And the capacity of in excess will shift from this FDG production site to these new fluorinated compounds. F18 could be replaced by gallium, copper, zirconium, but that will be on case by case. The conventional pharmaceutical industry, as I told you, is stepping in. But the pharma, so the big pharmas, are absolutely not interested in diagnostic. It's a modality for them. So that's also why there will be this split between therapy and diagnostics. They are interested in the theranostic approach, of course. And here I just want to show you that big pharmas have started. So we have the companies with some experience. We have the companies that have an R&D program or that have acquired this experience by hiring in people or by investing in these programs. There are companies that are investing in radiopharmaceutical companies. You have companies that are using radiopharmaceuticals for their development programs. And unfortunately, you have some companies that were pioneers that have stopped, and I'm just expecting that these companies will coming back. But if you look at the names here, you see almost most of the big pharmas. So that is the message here, is that the big pharmas are really coming with big aim, they want big projects. If we look at the molecule, I have tried to put on a single slide all the molecules that are supposed to, that have a chance to come on the market within the next 7 years. So all these molecules have in common that they are already in clinical trial, and they are all therapeutics, radiotherapeutics. So I have classified this by type of tumors, but even this classification is wrong, because in the future we will not develop molecules for brain cancer or for breast cancer, because it's the biological mechanisms that will be a priority. So for example, for PSMA, everybody knows that PSMA is not anymore a pure prostate cancer treatment, but PSMA could be used for many different cancers. So next time I will present you this table, I will try to list that by biological mechanism. But here, what is important here is what I want to just, I will not go through these different molecules. I want to just to show you the diversity of molecules, the number which is quite high, and we are only speaking about the next 7 years. I should add the molecules that for liquid cancer, and there are not necessarily only molecules used for oncology. There are other approaches. And the dates I have put that are my dates, so the date of potential coming on the market that are my estimations. Probably if you contact some companies, they will tell you they will be faster. If you contact the authorities, they will tell you, no, it will be later, because we decide. Okay, but we are in the range of the next 7 years. So from this table, I want to show you the same table, but with the name of the companies that are behind. And again, you will see which type of companies are, and we see the first big pharmas, Johnson & Johnson, Novartis, so Ipsen. So we see this new companies coming, and that is really important. And a third way is also to show you, because we are speaking about radiotheranostics, is that to each of these molecules, there is a molecule for diagnostic that is adapted or that is developed in common. There is, on this step, there is only one molecule that is right now on the market, which is Lutathera. So the other point is, how about the future of radionuclides? And for the next 8 to 10 years, we will work with a really limited number of radionuclides. Again, here we went through a natural selection, and we will use only the radionuclides for which we are sure that we are able to produce the amount required by the industry, in fact, by the patients. So for PET, the next generation of molecule will be based only on fluorine, gallium, zirconium, and copper. For SPECT technetium, we are still continuing speaking about iodine-123, but that's declining. And for therapy, lutetium and iodine, of course, but the alpha is coming, so I'm not promising that some alpha drugs will come on the market with a marketing authorization within the next 5 to 7 years, but we have to think that astatine and actinium are the most interesting. We have led to 12 just because there is one company behind it putting a lot of money, and we have TIN 117M that is also progressing, and that is an Auger electron, but that's interesting also for therapy. Next to that, we should take in account that some radionuclides will decline. And of course, it's not because it's bad. I mean, we will continue doing research with carbon-11, but in fact, carbon-11 will never translate in a large-scale product. Same for iodine-124. Gallium-67 is also disappearing. Indium is disappearing. Yttrium is disappearing. We had that in the previous discussion, but yttrium is not interesting because we have lutetium. And last one is, there are outsiders, but that is for research. So my interest is in copper-67, if we find a solution. So they always so if we find a solution to produce copper-67 in large amounts, of course, that's a really nice radionuclide. The family of scandium, the family of terbium is ideal because we have the smallest terbium alpha emitters in this family, and maybe some bismuth just because it will be a decay product from the actinium, and so we will have access to it. So that is my prediction for the next 7, 8 years. And everything that is not in this table, do not stop doing research, but it will be after 2025. Concerning personalized medicine, in fact, we have this definition. The most important definition for me is selection of positive responders for a specific therapy. But if you can define, if you can select your patients, what is important is that you reduce the cost of the overall treatment. So the interest is really the link with the reimbursement. So again, we are speaking about money. A drug comes on the market if there is a financial interest, not only for the industry, but for all the community and the states that are reimbursing. So reimbursement, we should even start with a project by asking ourselves, does this drug have a chance to be reimbursed one day? If this is the case, then you can go. That should be the first question. So, and from that derived the concept of theranostic, and even better, the radiotheraноstics. So to conclude, I just want to give you an overview of what could happen after 2025. So by that time, to my opinion, every single pharma company will have an interest in radiopharmaceuticals. Like today, almost all big pharma has an interest in antibodies. If you remember the stories of antibodies, they didn't want to invest in the 90s, and they waited until there was a success with antibodies, and suddenly they had plenty of money, putting 3-4 billion to acquire companies in antibodies, and afterwards everybody was interested in antibodies. We are exactly in the same situation. Suddenly the industry sees that there can be some success with radiopharmaceuticals, and then they are now investing in that. Lutetium will remain the priority. Next generation for me is really the copper family. Alpha therapy will come as well, but it will continue to be limited to actinium and astatine. We may have some approaches with thorium-227, bismuth-213. all drugs developed as pair of theranostics. I do not see other approaches than the one that are coupled or can be coupled with technetium, fluorine, copper, gallium, and zirconium as the diagnostic agent. And we can expect some future, if some people become more interested in the terbium and scandium families, then we can also expect to have these two families going further or developing. But today, there is no way to produce these two radionuclide in industrial amounts, and that is the limitation. And as long as that is not solved, the industry will not invest in these two radionuclides. So I know that some people have been frustrated not having seen the complete list of my radionuclides I've presented on the slides. If you want to see that, go to the 3w.oncidiumlife.org. You will have all this information, details with the explanation of these radionuclides. Just 2 words about Oncidium. Oncidium is a foundation that is promoting radiopharmaceutical and radiotheranostics. If you go on this site, it opens with a map for patients. It's intended to create a relation between patients and physicians, and you can put your own hospital that is using radiotherapeutics on this map just by entering or registering your hospital, and that will help the patients as well. I thank you for your attention.
Thank you very much for this introduction of all these potential developments. We have a few minutes for 1 or 2 questions.
I really appreciate your talk, and as nuclear medicine physician, it's good to hear. And I totally agree with you that the fact that big pharma steps in will help us or will change our discipline. But I have a question for you. Don't you think that the diagnostic market might be driven by the fact that authorities or insurances might require diagnostic tests as companion diagnostics for therapeutics?
Yeah. No, it's clear. We need the diagnostic. The only point is that the companies that are developing the therapeutics will rely on other companies that are specialized in diagnostics. So it's just a separation of the two activities. But we see some companies just saying, I'm developing the therapeutic, and if there is no diagnostic, I don't care. I will put that on the market. If there is a diagnostic, the risk is that it will shrink my markets. I will sell less because the diagnostic will select my patients. But here we are entering in another discussion, and some authorities are just considering that maybe we should reimburse only the drugs that are, or the treatment that are efficient. So the industry will be asked to reimburse the therapy if it doesn't work. So the only way to give the treatment only to positive responders is to select the positive responders.
Thank you for a fabulous presentation. My question is, why do we think it will cost less for patients to get radionucleotide therapies? For example, if we're attaching them to antibodies, that's not going to decrease the cost of these antibodies. Once we go through generic ligands, then there will be a proliferation of proprietary specific ligands. So do we think it will be cheaper for patients?
The price, the discussion about the price has nothing to do with the amount. In reality, the amount of antibody we are using in a final dose of radiotherapeutic is quite small compared to the antibody we are using in a cold treatment. So this should already be the difference. But you should never forget that the price of the raw material in any drug is less than 5 or 10% of the total price of the drug. What you are paying for a drug is the cost of development. When a company invests $3 billion in a drug for the whole research, this company is expected to have as revenue $3 billion per year at plateau. That is the rule. So Novartis is expecting to have $4 billion, to make $4 billion per year in the next at plateau. So in 2-3 years, that should be the routine. And in this sense, Bayer has failed because they have reached only 400 million this year.
Yeah, I think therein lies the problem. We're entering a very risky period in the development of theranostics because we have the example that over 30 years, academic centres have developed diagnostic and therapeutic pairs, done clinical trials in their centres, mainly retrospective, not terribly well designed, but nevertheless showing very good efficacy, very good safety. And then a company comes in and does one trial that simply validates what we all knew from using it for 10 years or more, and they're making billions of dollars out of it in being acquired by a secondary company that then wants to sell that product at a sufficient cost to recoup the very large increment that they've put on the value of this product. And suddenly, what was a relatively cheap therapy becomes an incredibly expensive therapy that takes it out of the hands of anyone who doesn't have insurance, who doesn't have access to a public healthcare system, and limits the market of that therapy. You mentioned the issue of companion diagnostics, where precision medicine should be saying who can't benefit. That's the real advantage of theranostics, who can't. And I've been through that because we were involved in the early development of hypoxia-targeted chemotherapeutic agents. And we told the FDA and we told the company that we have a companion diagnostic. We can image hypoxia, and we know that hypoxia is only present in a small percentage of certain diseases. And that's the only subgroup in whom this drug is going to work. But the company involved were not at all interested in using that companion diagnostic because it potentially limited their market. They wanted 100% of patients to have a drug even if only 20% of them were going to benefit from it, because it was a big market. My argument to them was you get 100% of the 20% of patients who have the target if it's a very effective therapy. And as it turned out, tirapazamine died because they didn't use a companion diagnostic. Maybe that will be the lesson that pharma learns, but it's a risky game that we have the track record of developing effective and safe therapeutics, and industry have a big chance of cocking that up.
I completely agree, but one point is that I am working with the industry, but I'm not paid by the industry, so I have a kind of freedom to speak, which helps me also to explain you what are the rules for the industry. The price are mainly, I do not want to enter in the discussion about price of a drug, but all the costs of the development is also driven by the authorities, who are now asking so many clinical trials. If you fail one, you fail a whole development program. And the message here for me is simply that drugs that will come on the market will have to pass through this process and go through clinical trials that are sponsored, so really expensive, because the authorities are also asking the phase 1 to phase 3 trials, which become really expensive. So we should put more pressure on the authorities. We have a tool that allows us to do clinical trials with less patients, with shorter, and that may also decrease the price of the drugs.
Rich, last question before we go to the break.
Oh, yes, sir. I really enjoyed your presentation. More optimism than I expected. It was wonderful. But could you talk about what would be realistic models for pay for performance? That is, some of our drugs are not going to be curative, they're going to be palliative. The physician effort in giving a drug will be probably comparable whether or not the drug works. Are you aware of any models that you can envision for radiopharmaceuticals that would deal with drugs that aren't curative, how do you think it will work?
Everything is open. We didn't speak about combination between radiopharmaceuticals and chemotherapies. I mean, it's really the work now from physicians to use these tools and to combine, to play with doses, to play with different sub-indications, to play with different diagnostic agents. I mean, we have one diagnostic agent and a patient, but there are plenty of different criteria we could use to select patients. So I cannot answer to your questions because it's too broad. But the more we will have drugs that are approved on the market, the more you will be able to select what is the best for your patient. So we should really help or push the industry to bring more and more drugs on the market. What has really changed here is that in the past, you spoke about hypoxia agents and that didn't come on the market, is simply because the research people forgot that what's important, industry wants to have a safety in, or have a kind of monopoly when they invest such amount of money. They want to keep that for themselves, at least for a certain period of time. The orphan drug status is something really important. The patent is more important. I gave a similar lecture last year. The title of the lecture was are you expecting to get Nobel Prize or becoming millionaire? You have to choose as a research if you want to help the patients and to bring new drugs or to develop your drug, but do not take patents. It's just for your small community. But maybe you will reach the Nobel Prize. But on the other hand, if you wait before publishing, you will get you may have a chance to have your drug coming on the market. And in this conference, for example, I didn't see a lot of new molecules, or at least I know a lot, so I didn't discover new molecules here. But maybe the reason is because the people have understood this message, and now there are plenty of molecules that are under development that nobody speaks about, and we will see them suddenly, but with a company, with a society, a company behind it, and with budget and with a patent. So that is, we are really in a big change, and this change started 2 years ago.
Thank you very much for these recommendations. I particularly thank all the speakers for taking those challenging subjects, and invite all of you to go to our tea break. Thank you very much.